Hi and welcome back to another video of Medic Notes. This video is on Crohn's disease. Crohn's disease is one of the main types of inflammatory bowel disease, the other being ulcerative colitis. Crohn's disease is slightly less common than ulcerative colitis, and it has a bimodal peak age of presentation of between 15 to 30 years, and then again at 60 to 80 years. The disease typically follows a remitting and relapsing course. Crohn's disease can affect any part of the gastrointestinal tract, from mouth to anus. Although commonly targets the distal ileum or proximal colon, it is characterized by transmural inflammation, which means it affects all layers of the bowel in the affected region of bowel, producing deep ulcers and fissures, showing a cobblestone appearance. Shown in this lower picture here, the inflammation is not continuous, so it forms skip lesions throughout the bowel. Due to the transmural nature of the inflammation, fistula can form from affected bowel to adjacent structures, resulting in perianal fistula, enteroenteric fistula, rectovaginal, enterocutaneous fistula, or enterovesicular fistula. The microscopic appearance of Crohn's disease is non-caseating granulomatous inflammation. Crohn's disease is often compared with ulcerative colitis, which is another common inflammatory bowel disease. This is a table listing their differences. Ulcerative colitis only affects the large bowel, whereas Crohn's disease involves the entire GI tract. Only mucosal inflammation in ulcerative colitis, but transmural inflammation in Crohn's disease. For microscopic changes, in ulcerative colitis, we can see crypt abscess formation, reduced goblet cells, and it is non-granulomatous. Whereas for Crohn's disease, we can see non-caseating granuloma formation. Other specific characteristics of Crohn's disease are skip lesions, fissures forming cobblestone appearance, and fistula formation. The main risk factors for Crohn's disease include strong family history and smoking. For clinical features, Crohn's disease typically presents with episodic abdominal pain and diarrhea. The abdominal pain may be colicky in nature and will vary in site depending on the region of bowel involved. Diarrhea is often chronic and may contain blood or mucus. Systemic symptoms include malaise, anorexia, and low-grade fever. As the disease affects the entire GI tract, both oral and perianal involvement are common as well. There are also extra-intestinal features, musculoskeletal, such as enteropathic arthritis, typically affecting sacroiliac and other large joints. Nail clubbing, or with metabolic bone disease, secondary to malabsorption. Skin, either as erythema nodosum, which are tender red-purple subcutaneous nodules, typically on the shins, or pyoderma gangrenosum, which are erythematous papules or pustules that develop into deep ulcers. Eyes may have episcleritis, anterior uveitis, or iritis. Hepatobiliary, primary sclerosing cholangitis, cholangiocarcinoma, or gallstones. And for renal stones. This picture shows the erythema nodosum on left, and pyoderma gangrenosum on right. For investigations, routine bloods are required to examine for anemia. Check for low albumin secondary to systemic illness, and evidence of inflammation, shown by raised CRP and WCC. A fecal calprotectin test should be performed in all patients with recent onset lower gastrointestinal symptoms, with a good sensitivity for inflammatory bowel disease. A stool sample for any potential infective cause should also be sent. However, colonoscopy is the gold standard investigation, whereby biopsies can be taken to confirm the diagnosis. The Montreal score can be used to classify disease severity of Crohn's disease, based on the age at diagnosis, the location of lesions, and the behavior, whether it is stricturing or penetrating. Add a P if there is concurrent perianal disease. For imaging investigation, a CT scan abdomen pelvis is usually done in severe Crohn's disease, as it can demonstrate bowel obstruction, bowel perforation, or intra-abdominal collections. MRI imaging can also be used to assess disease severity. Subsequent examination under anesthesia, with proctosigmoidoscopy, may also be considered to examine and treat perianal fistula. For management, first to induce remission, give aggressive fluid resuscitation, nutritional support, prophylactic heparin, and anti-embolic stockings. Due to the prothrombotic state of flares, medical treat MNED include corticosteroids, immunosuppressive agent like mesalazine and azathioprine, biological agent like infliximab and adalimumab. Next, for maintaining remission, azathioprine is recommended as a monotherapy to maintain remission as first line. Smoking cessation is also advised. Due to increased risk of colorectal malignancy, colonoscopic surveillance is offered to high-risk patients. Patients should be referred to IBD nurse specialists and patient support groups. Enteral nutritional support should be considered in young patients with growth concerns. Around 70 to 80% of Crohn's patients require surgery at some point in their lifetime. Surgical intervention is indicated in those with failed medical management or severe complications, such as strictures or perforation. Operations that are commonly required in patients with Crohn's disease include ileocecal resection, which is the removal of terminal ileum and cecum, with primary anastomosis. Small bowel resection or large bowel resection. Surgery for perianal disease, such as abscess drainage. And stricturoplasty, which is the division of a stricture that is causing bowel obstruction. For complications, gastrointestinal complications include fistula and stricture formation. Recurrent perianal fistulae. GI malignancy. Patients with Crohn's disease have about a 3% risk of developing colorectal cancer over 10 years, and small bowel cancer is about 30 times more common in those with Crohn's disease. Whereas for extra-intestinal complications, are malabsorption, osteoporosis, secondary to malabsorption or long-term steroid use. Increased risk of gallstones, due to reduced reabsorption of bile salts at the terminal ileum. And increased risk of renal stones. That's all for this video. Thank you.